Paramedic primary healthcare headache assessment. We've been called to a 50-year-old male who's had a headache for the last hour. It's unilateral, left-sided, temporal region behind his left eye. At worst, the pain was 7 out of 10. It's now approximately about 5 out of 10. It's a slow-building headache. He's got mild photophobia with some associated nausea. We take a full history from the patient. There's no difference to this headache. He has got a history of migraines. The only slight difference is that they are becoming more frequent. He's getting one every couple of weeks. He hasn't been to see his doctor. He's on no migraine medications. He's not on any anticoagulants. He denies any trauma. He hasn't hit his head. His oral intake is normal and his toileting is normal. There's been no specific activity that is brought on this headache. Areas of concern for us would be if there was a rapid onset and it was blinding in nature, if there was any seizure activity, any altered level of consciousness that might indicate a cerebral bleed. There is no history or family history of cerebral bleeds. He has no allergies and he's currently taken no medications for this headache. He's got no issues with his speech, no aphasia, dysarthria or dysphagia. Differential diagnoses, we would be looking for hypertension, any indicators for cerebral aneurysm or stroke, issues that could be brought on by a tumour, temporal arteritis, any sinus issues, any muscle spasms that may be associated with the headache. Treatment options that we can consider are oral medications. With migraine we can give fluids. Opiates are not specifically indicated, but they aren't contraindicated either, depending on the severity. Okay, so we've gained Richard's consent to do this procedure and explain to him what we are going to do. While we've been talking to Richard and gaining his history, my partner's done a full set of baselines and there are no abnormalities. So Richard, I'd just like to have a bit of a feel of your face if that's all right. Yeah. Okay, I'm just going to squeeze you just around your sinuses. No issue there, any temples,
no.
Above your eyes there?
No, that's fine.
No scalp tenderness?
No.
How about your back of your neck?
Oh, that's fine.
That's all okay?
Yeah.
Okay, just raise your shoulders up for me. Just raise your shoulders and down, relax again. No issue there?
No.
Right, just follow my finger. No problem there.
No.
No. Touch my finger. Over here. Over here. Down here. That's all good. That's all good. Poke your tongue out for me. Open your mouth. Try and shut your mouth. Okay. No pain under here.
No, it's good.
All right. Just head to one side, back to the other. Chin on your chest. Flex your head right back.
Yeah.
No issue there.
No, it's
Okay,
okay.
great. All right. Just have a quick look in your eyes. Okay, that's all fine. All right. So we've basically looked to check for stroke, any other issues like the temporal arteritis. There are no issues there. Just one last test. Just grab my hands, squeeze my fingers, hands straight out. That's great. Hands straight out in front of you, palms upwards. Close your eyes. Great. All right, you can relax. Right. So I think Richard's basically just has a migraine headache. The issue is that they're more frequent. So we're going to give Richard some medications. We can give him, for this particular issue, his weight is about 85 kilos. We can give him 1.5 grams of paracetamol. I can give him 600 milligrams of ibuprofen. Let's give you those. 1, 2, 3. Great, 3 of each. And prior to giving these medications, we've also done a drug check to make sure that they are the correct medications and they are in date. The other medication that we can give here is 50 milligrams of tramadol. We're then going to take a bit of a step back and my partner and myself will check out for any red flags associated with the headache. So the headache or neck pain was not following manipulation. Then there is no neck pain or neck stiffness. The headache was not sudden onset or severe. He is not febrile, and there are no flu-like symptoms. There is no persistent or severe vomiting, no focal neurology. There's no altered level of consciousness or a history of an altered level of consciousness with the onset of the headache. The headache is not worsening and is not related to a recent trauma. He's not taking anticoagulants. There's no signs of the temporal arteritis. There's no hypertension. We would be concerned with a female patient if there was hypertension and she was pregnant. There's no previous history of intracranial bleeding, no family history of cerebral vascular abnormalities, and the onset of the headache was not during sexual activity. So after we've paused and done this check, we would then check our non-transport checklist as well. And provided there are no issues with the non-transport checklist, if we had decided to leave the patient at home, then we are clear to leave that patient at home. We do need to make sure that we leave the correct paperwork with the patient in case there's an issue later on. For a patient in Richard's situation, we would advise that as the frequency of the headaches has increased, that he sees his doctor as soon as possible. If there is, we can arrange that for Richard while we are here, or if he's got a family member that can do that for him. We would just like to make sure that there's somebody that's going to stay with Richard, as we've given tramadol. Somebody with Richard would be a good thing to do. And if there was any issue prior to seeing the doctor, he can call the ambulance back. We've been called to a 56-year-old male who's had a sneezing fit. He's blown his nose and now has a nosebleed, epistaxis. It's been bleeding for the last hour and he's unable to control the bleeding. He does have a history of nosebleeds in the past, but denies any specific trauma leading up to this event. It looks like he can't stop the bleeding. He's using the incorrect technique. He's got his head tilted back and he's squeezing the upper bony part of his nose. He's not on any anticoagulants. It's important that we gain a full history and to ascertain that he has not undergone any surgery recently. He doesn't have any blood disorders and he has no allergies. We do a full set of baselines. We're concerned with hypertension and specifically prolonged hypertension. We need to gain consent to do the following procedures with this patient and explain the procedures to them. So for uncontrolled epistaxis, we're going to administer some intranasal adrenaline. To do so, we need a 10 ml syringe, a 3 ml syringe, a 10 ml of sodium chloride, an MAD, a mucosal atomizing device, a draw-up needle, and 1 milligram of adrenaline, which we would check with our partner that it is adrenaline and its expiry date. So use 10 ml syringe. We draw up 9 mils of saline. That's 9 mils of saline. We attach our draw up needle. Get rid of our sharps. Drop the adrenaline. Sharps. Then out of our solution, which is now, we have a 10 ml solution, which is made up of 1 ml of adrenaline and 9 mls of saline, giving us a mix of 1 in 10,000. We're then going to draw up 2 mls of solution, which is 0.2 milligrams of adrenaline. We'll actually draw up 2.2 mils. That gives us enough to prime the atomizing device. 2.2 mil. Then going to remove, attach our atomizing device, and that's prepped. We could label that with an adrenaline sticker, and that's ready to use. Okay, Richard, your nose is still bleeding. I just need you to what I want you to do is just show the technique to squeeze your nose properly. So I just want you to squeeze it on the soft part of your nose, just below the bony bit. All right, you're going to squeeze that for 15 minutes. So once the patient has squeezed or pinched their nose there for 15 minutes, if they're not quite doing the technique right, we can assist with that. Once they have done that, we put an ice pack around the back of the neck as well, which can aid in that the blood cessation. We've explained them to pinch the cartilage, not the bony part. We're going to check after 15 minutes if it's still bleeding. If it is still bleeding, then we're going to get them to blow their nose to clear any clots, and then we're going to apply the adrenaline, which we've already checked and loaded. We're going to apply that up that only the nostril that is bleeding. So Richard, what I'm going to do, if you blow your nose and just check that, we'll get rid of those clots. You can do that for me.
Yeah.
Thank you. All right, just let go of your nose there. What I want you to do is tip your head back, and I'm going to squirt this up your nose, and I just want you to breathe in through your nose, not really, don't give a big sniff, just quite a light sniff up into your nose. All right, so I'm just priming that, so we've now left for 2 mils once it's primed. What we're going to do is insert that into the nostril, and then ready, on 3 we're going to just sniff in gently. 1, 2, 3, great. And tip your head forward again. Alrighty, you might feel a bit of it running down the back of your throat. That's okay. And just squeeze that same spot again, up a little bit higher. That's it. Just squeeze that again. You're going to squeeze that for another 15 minutes. Then we're going to check again to see if there is a bleed, if the nose is still bleeding. If it is still bleeding, then we need to think of an alternate pathway to try and get this sorted out. If it isn't bleeding, then we will go through our non-transport checklist just to make sure there are no abnormalities, and that we've covered off that we're able to leave this patient at home. We can suggest that he then goes and sees his doctor just to get them to have a look and make sure that there are no issues with any vessels up the nose, and the necessary the need to go and have a further procedure done after that. We can consider packing the nostril if we think that is necessary. If that is necessary, we would need to transport them either to their doctor or through to an emergency department. So part of our assessment is that we need to try and ascertain the volume of blood loss, which can be difficult when it's soaked up into cloths and rags and that type of thing. The other thing that we must make sure that we do is explain to the patient that you need to leave your nose alone now. Don't put your fingers up there, and don't blow it. Don't try and rub it. We don't want to, no hot drinks or hot showers or that type of thing, just for a little while, to let it settle down, let the adrenaline work.
Okay. Yeah.
Okay, we've been called to a 55-year-old male who has been playing soccer. He's done a stop and try to change direction, and he's heard a popping sound and felt a snapping sound in his left knee. The pain immediately was very sharp, an 8 out of 10. He hasn't been able to weight bear since. He now has a dull ache in that knee, unless it's moving, in which case the pain is sharp. He has no medical history, but he does have a previous history with this knee of a hyperextension when he was about 16 years old. So we talked to our patient. We gave him and said, look, is it okay if I have a look at your knee? I'll try to be as gentle as I can, but I might be a little bit sore, but we need to work out what's going on. So we gained consent. We've exposed both of our legs. We need to examine the knee. We're looking for asymmetry, i.e. swelling. We're looking for bruising, any obvious deformity, structural deformity, and any disposition of the patella. So you may be looking for the patella more proximal to the hip, or it might be on the lateral aspect, most likely if it is a patella dislocation. So the first thing we're going to do is I'm looking at both the legs from end on. I'm looking for any obvious swelling or bruising in the damaged knee. Sensation, you can feel me touching down your legs?
Yeah.
Can you raise your toes to your face? Hurt when you do that?
Yeah, that's sore.
A little bit sore. And I'm just going to have a bit of a feel. I'm watching you, wincing a bit there as I'm feeling around that. And then we've got a little bit of swelling in that as well. Can you bend your knee at all? Can you bend your knee upwards? Fraction?
Yeah.
Any better than that? Okay,
Sorry.
Okay, from there I'm just going to put a little bit of pressure on that knee. Is it hurt as I'm putting the knee there? It does hurt a little bit. Okay, I'm just going to lift your knee. I'm looking for some
Ooh, sorry.
trying to do that rotation.
Yeah.
Okay, aggravate that too much more. So we've got obvious pain on movement there. I haven't been too aggressive with the manipulation. You know, I mean, there could be some damage in there. We don't want to worsen any damage, but we have an obvious injury there, and we need to treat it accordingly. So we're going to check our distal baselines, and we compare both legs. So we check for pedal pulses. I've actually got two. Our colour's good, so we've got no deficits there. Both feet feel warm. There are no differences between the two. We would also at this point gain some full set of baselines. We question our patient: have you got any allergies to anything? No. You haven't had any pain relief so far today? Okay, so we can get on board our standard oral pain relief. Our patient is above 80 kilos, so we would look at 1.5 grams of paracetamol. We could look at 600 milligrams of ibuprofen, a nice anti-inflammatory, and we could look at some tramadol as well. We don't have any allergies. We can also look at splinting the knee just to take some of the mobility issue away from it and try and stabilise it a little bit. While we're doing that, we can look at giving the patient some inch knocks, provided that's not contraindicated. We could also look at methoxyfluorine. Depending on the level of pain, we can look for some either IV access for some opiates. If we were looking having to relocate, we look at either IV or intranasal fentanyl. That's fast acting and short acting. It allows us to do that manipulation. Morphine a little bit slower acting if we need to get some more extensive pain relief. So splint the knee. This patient we would look at transporting to either an accident emergency that has X-ray facilities or through to the hospital, through to ED for further assessment. So we've been called today to a 50-year-old male this morning getting dressed. He's been putting on his socks and he's felt a pop in his lower back. He does have a history of lumbar spine pain. Slightly different this time in that he's got pain radiating down his right leg. He also has some reduced mobility, but he's had no issue with bladder or bowel. He has been able to walk around today. The pain was severe at onset. It is now quite dull. But he does get sharp stabs of pain when he tries to walk around. He has taken his own anti-inflammatory diclofenac this morning. He's lying on the floor, stating that he likes to lie on the floor because it's a nice solid surface and it feels better on his back. We gain a full history from the patient and establish that he has no allergies. From here we want to do an assessment of his lumbar spine. Are you happy, Richard, if I have a bit of a look at your back?
Yeah, that's fine.
Okay, so at the moment you've got a bit of pain down that right leg. So to do the assessment, we're going to firstly roll the patient onto his side, expose the lower part of his back, and just have a look see if we can see any bruising or any deformity there. Are you happy, Richard? Just nice and easy, just roll onto your left side. That's right.
Oh, yeah.
All right, not too bad. So exposing the back here, just feeling down the centre of your back. Tell me if it hurts on the way down.
It's getting more.
Yep.
Yeah, right there.
Okay, sore there. How about on the side here?
A little bit.
A little bit on that left side, right side.
Yeah. No, it's okay there.
Not too bad.
Not as bad.
Roll back onto your back for me, just nice and easy. All right, I'm just going to come around the other side here now. Can you feel me touching both your legs?
Yeah.
Yep, no strange sensation there. Just have a feel of your tummy, is that all right?
Yeah, that's fine.
Okay, just going to palpate, just a bit of palpation here. Any increase in pain there?
No, that's fine.
No strange sensations as on?
No.
Okay, you can just put your top back down. All right, so any pain in your groin at all?
No.
No pain in your groin. Alrighty. So we've had a look at the back. Now, can you just bend your knee up? All right,
Yeah.
no problem there.
That's okay.
Okay, try on the other leg.
That's a bit more sore.
Okay, alrighty. Straight, put them back down on the floor with that there. Just push against my issue there.
Yeah, that's fine.
Not too bad.
Yeah.
No pain pushing on that other side. Okay. So from here we need to think about some pain relief for this patient, and what we're going to do moving forward. Initially, to get the patient to sit up, we could administer Internox, of course, checking that there were no contraindications to do so, and we could utilise Internox. You have been moving around today, so let's just sit you up nice and gently.
Okay.
We just sit you up on the. You happy there? Yeah, you do. All right. Not too bad.
Yeah, that's fine.
Now we've got you up, we can administer our oral medications, looking at paracetamol, ibuprofen, and tramadol. He's now in a position that he can swallow those. We're then going to stand you up, get you to stand up onto your feet. So if you grab hold of my hand here, Richard. All right. Nice and easy, nice and easy.
Ah, yeah.
How's that standing up?
It's better. Well, it's just the getting up is kind of sore.
Yeah.
No, it's okay.
How's that pain down your right leg?
It's okay. It's not too much.
Not too bad. Just take a couple of steps around in the circle there. So we need to make sure that the patient is mobilising properly. We would go through our red flag checklist just to make sure that there are no issues. If we decide that we need to transport this patient to hospital, we can do. Richard is able to mobilise. He can get himself to the toilet and look after himself once that pain relief has kicked in. So we'll run through our non-transport checklist and then advise that Richard, if he has any other problems or anything acute happens again, you can call us back or pop along to your doctor and just go through that process. He might send you for an X-ray and some physio.
Yeah.
You happy with that?
Yeah.
Okay. A red flag checklist for lumbar back pain, no loss of bladder or bowel control, not febrile at greater than 38 degrees with Rigers, no abnormal vital signs, no pain in the thoracic spine or chest, no abdominal pain or tenderness, no altered level of sensation in the saddle area, altered sensation and or power in both legs, unable to walk, signs and symptoms of generalised illness, pain radiating down both legs.